Back pain is the commonest cause of reported pain to healthcare facilities. More than 80% of people will have at least one episode in their lifetime. Most are benign and will resolve. However, 33% to 66% will have a recurrence within a year. And it's important to identify red and yellow flags. It may be acute if it is less than 3 months and chronic if it is more. Few things to note on back pain. So yellow flags as pessimistic attitude toward pain, excessive fear of movement and activity, and little hope for improvement. And so work-related problems, for example, dissatisfaction and conflict. And also emotional problems, for example, depression, anxiety, worry, and generalized pain, for example, headache, fatigue, dizziness. Desire for passive treatment, has little ability to be proactive. Also, previous episodes of low back pain that were followed for an extended period of time. Red flags are patients less than 20 years or more than 55 years of age experiencing back pain for the first time, and patients experiencing pain significantly different from previous episodes, and pain that is constant over time and does not disappear during sleep. General malaise and poor general condition, also traumatic injuries, tumors, steroid use, or improper use of immunosuppressant, neurological compromise, spinal deformity, pronounced morning stiffness lasting for longer than 1 hour, or high erythrocyte sedimentation rate. The causes are mechanical, for example, disc degeneration, fractured vertebra, instability, and unknown causes in most cases. And so it could be neurogenic, for example, herniated disc, spinal stenosis, osteophyte damage to nerve roots. Also, non-mechanical spinal conditions, for example, neoplasm, infections, inflammatory arthritis, and Paget's disease. And referred visceral pain, for example, gastrointestinal disease, kidney disease, and abdominal aortic aneurysm, and other, for example, fibromyalgia, somatoform disorder, as faking pain. Symptoms are pain as nociceptive, could be diffused pain, or neuropathic, as pricking, tingling, pins and needles, electric shocks of shooting, hot or burning, numbness, altered sensation, and radicular pain, and also incontinence of urine and feces. The signs that are usually elicited are deformity of spine, tenderness in affected region, weakness of the affected limb, muscle wasting in the affected limb, altered sensation in the affected limb. Investigations, the criteria, ACR, and the recommendation. So uncomplicated acute low back pain, imaging usually not appropriate, low velocity trauma, osteoporosis or age more than 70 years, and low back pain or radiculopathy in surgical or interventional candidates. Commendation, do an MRI of lumbar spine without contrast, usually appropriate. And suspicion of cancer, infection or immunosuppression, prior lumbar surgery, and cauda equina syndrome. So MRI of lumbar spine with or without contrast, usually appropriate. Okay, so other investigations are FBC, ESR, MAN2 test, chest X-ray if TB is suspected, rheumatoid factor, HLA B27 if inflammatory arthritis is suspected, and CT scan of spine, CT myelogram, plain X-rays of spine. So the main treatment objectives are to relieve pain, prevention of recurrence, identification of red and yellow flags, treatment of underlying cause, improvement of function, non-pharmacological treatment, splints, physiotherapy, weight loss and lifestyle adjustment, acupuncture, sleep hygiene, occupational therapy. Pharmacological treatment for relief of acute back pain. First line treatment, you give paracetamol oral 500 milligrams to 1 gram, 6 to 8 hourly, and naproxen EC oral 250 to 500 milligrams 12 hourly as required, or cholicoxib oral 400 milligrams that, and then 200 milligrams 12 to 24 hourly as required, or diclofenac oral 50 milligrams 8 hourly, or 100 milligrams 12 hourly, or ibuprofen oral 400 milligrams 6 to 8 hourly, and diazepam oral 5 milligrams 12 hourly, or methyl carbamol or tizanidine. So for tizanidine and methylcarbamol, you have to consult a specialist. The second line treatment, you can give amitriptyline oral as when there are neuropathic signs and symptoms, as 25 to 50 milligrams daily, or pregabalins oral, you consult a specialist. And then you give tramadol oral 25 milligrams that, and then you increase by 25 to 50 milligrams daily up to 50 to 100 milligrams 6 hourly as necessary, with a maximum of 400 milligrams per day, or codeine oral 15 to 60 milligrams 4 to 6 hourly as required, or morphine sulfate oral 5 to 10 milligrams 8 to 12 hourly. For inflammatory arthritis, you give prednisolone oral or methotrexate oral, and rituximab or rituximab IV. And in these medications, you have to consult a specialist. Referral criteria: individuals may need to be referred to the orthopedic specialist, neurosurgeon, or rheumatologist based on the red and yellow flag criteria.